Caring for healthcare. This is Anna Marie Markle. In 2017, she was diagnosed with stage 3 ovarian cancer. Shortly after, she was laid off from the firm she worked at for 20 years due to her increased medical-related absences. She was given a 1-year severance and healthcare insurance, but after this, she was forced to pay her copays to Cobra, an insurance company providing coverage to those who recently lost their jobs or taken a reduction in work hours. Ultimately, the cost of healthcare became too much for Anna Marie, and she died at age 52.
Anna Maria's story is just one example of millions of Americans who struggle to find effective healthcare due to their socioeconomic status. According to the National Institute of Health, 46.2 million people live in poverty, which, as of 2022, can be defined by Human Health Services as an individual who makes below $13,590 annually.
According to a 2020 article, the United States spends the most out of any developed nation on healthcare insurance, but ranks 24th on a list of nations with the best healthcare insurance. This means that the United States spends a significant amount of money on doctors' salaries and medical supplies and fails to provide adequate coverage to the low socioeconomic. In fact, up to 25% of Americans say that they have either delayed or foregone medical treatment due to extreme cost of healthcare.
This brings us to our problem, which is living in an impoverished community. Due to the inability of those under the poverty line to receive proper healthcare services, there's an increased risk for disease. Published in the Public Library of Science, Nicole Mode states that living in poverty directly correlates to an increased risk for disease. Health issues such as heart disease, malaria, HIV, and AIDS are the most common.
There are a few number of short-term healthcare facilities located in areas where most of the people are considered low socioeconomic. This is because these people living in these low-income communities either cannot afford healthcare or their health insurance companies requires them to pay very little out of pocket to meet their deductible. This means that these companies pull out of the low-income communities in order to maximize profit elsewhere.
An in-depth example of how living in poverty can affect your physical well-being is the rates of heart disease within these communities. According to the University of California, San Francisco Department of Epidemiology, around 70% of excessive heart disease is caused by the stress of living in an impoverished community. These heart diseases can range from arrhythmias, hypertension, or even having a fatal heart attack.
According to an article published by the UT Southwestern Medical Center, it would set you back $53,384 to have a heart attack. This includes chest x-rays, EKGs, possible surgery, and an overnight hospital stay.
In 2021, the average deductible, which is money necessary to be paid out of pocket before insurance coverage begins, was $2,825 according to eHealth, which impoverished individuals likely do not just have lying around.
Even federal assistance programs like Medicaid, which provides insurance coverage for impoverished based off their income, has a deductible that is on average around $1,500. And if we follow HHS guidelines, that is 1/13 of an individual's annual income just to seek treatment at a doctor's office once. Furthermore, there is huge gaps in coverage in Medicaid itself. According to the Kaiser Family Foundation, those above 41% of the federal poverty line may be covered. However, those in between 41 and 100% are not covered by any insurance due to differences in state level and federal level guidelines. This leaves magnitudes of individuals who are not covered by insurance and having to burden the heavy costs that the U.S. healthcare system places on them.
So this brings us to the question of how can the U.S. expand healthcare coverage for all?
Our first solution is the deprivatization of hospitals. Instead of hospitals being run by companies or small groups of individuals, they'll be federally funded. This allows for hospitals to switch their focus from maximizing profit to caring for individuals, which would allow them to expand into lower income communities, and that would increase the amount of hospitals, which would decrease the overall cost of healthcare.
This brings us to the limitations of the deprivatization of hospitals. With the deprivatization of hospitals, this would mean a lower salary for doctors. Netherlands, the highest paying country in the EU, which has universal health care, pays general practitioners on average $117,000 per year, while in the US, the average salary for general practitioners is $220,000 per year. As well as with this lowered salary, there would be a lower desire to enter the medical field. As well as these doctors are being paid less and less, there'd still be ever increasing student loans to pay. As well as this would be a dramatic change in healthcare for hospitals to go for-profit to non-profit.
The second solution we're presenting is to increase federal funding through a hike in taxes. While keeping hospitals still as for-profit systems, both federal and state level governments would provide more funding to hospitals. This would lower healthcare costs and cheaper fees. According to J.P. Griffin Group, it costs $22.76 to spend a night in France at a hospital. compared to the People Care report showing that it costs $9,300 on average for an uninsured individual to spend the night in a U.S. hospital. This increased funding would also allocate hospitals to be able to purchase more resources and supplies, or even hire more personnel to now handle the increased uptake of patients seeking cheaper healthcare.
Some limitations for federal funding are money has to come from somewhere, which would mean a likely increase in taxes, and that would obviously not be a very popular solution. And also, since there is an increase in the amount of hospitals, there would be an increase in the amount of workers needed to work there.
This brings us to our third solution, which would be to close the gap, furthermore, implement federally controlled Medicaid. Due to the federal regulations of Medicaid being extremely broad in the United States, eligibility differs across different states. If federally controlled Medicaid was implemented, the government could comply and make all citizens in need of Medicaid eligible.
If the United States expands Medicaid to more people living under the federal poverty line, these people would be better equipped to handle the extreme cost of healthcare, thus closing the gap.
The graph depicted here shows how expanding Medicaid across the United States can be beneficial. During the period between 2014 to 2017, 19,200 lives were saved in expansion states, although 15,600 lives were lost in non-expansion states.
Despite the seemingly great benefits of expanding Medicaid, there are many drawbacks. First of them being the enormous cost that state and federal governments would have to burden in order to expand Medicaid to everyone. According to the Georgia Budget Policy Institute, a report states that it would cost Georgia $353 million after subtracting their net revenue to expand Medicaid to every individual within the state. This would also create high bipartisan disagreement among the two parties who argue whether or not Medicaid should even exist in the first place. As shown in this Kaiser Family Foundation graphic, deep red states like Texas and Florida refuse to adopt new Medicaid policies, while Democratic states like Washington or New York have adopted policies for years and will continue to do so.
So, which solution to pick?
Increasing federal funding through hike in taxes.
So why? If we implemented federal funding, there would be gradual changes. Unlike the deprivatization of hospitals, the slow rise in taxes would not gradually upset people.
Since hospitals will remain for-profit, they'll make the same amount of money, which allows for stable salaries.
And finally, this would increase the U.S. health system's overall ranking, pulling us up from the 24th and lower 25th percentile, while still maintaining a more socially and fiscally responsible policy.
Okay. Matthew, what is an example of a compelling argument from one of your peers' individual reports that you decided to exclude with your team presentation, and why?
In Campbell's IRR, she went really into depth about the preconceived notions that people can have regarding race or the way you appear in healthcare, but it was a little too broad for the presentation we're going for, and so we excluded the discussion about how racism affects healthcare.
Okay. And Jay, reflecting on your colleagues' work, which one had the greatest impact on your overall understanding of the problem your group identified?
I think Matthew's IRR had the greatest impact on my understanding because I originally saw poverty as something that an individual goes through, and Matthew talked a lot about how families are involved in the impoverished and how if one person is in poverty in the family, the entire family suffers.
And Campbell, what is a way in which your team's resolution makes you think differently about your own individual research?
I think my team's resolution made me think differently about just the overall view on healthcare and how kind of, I guess, there's a lot of factors that play into healthcare. In Matthew's IRR, he talked more about certain incomes that come in, and that really shaped the way I thought about it.
Okay. All right.